All right, let's talk preterm labor. And listen, this isn't just a topic for your NCLEX. It's pretty much a guarantee you'll see it. So we're going to cut right to the chase, just the stuff you absolutely need to know to pass.
I'm not kidding. Stop scrolling right now. Preterm labor is going to be on your exam, period. What we're about to cover are those high-yield must-know facts that are going to get you those points. So let's do this.
Okay, first things first, the core definition, and you got to know this verbatim for the NCLEX. Preterm labor is uterine contractions and cervical changes happening between 20 and 37 weeks of gestation. The key word there is and. You need both for it to count. That's a huge distinction.
All right, let's talk triggers. The NCLEX loves to test the most common causes, and honestly, they're simpler than you'd think. Number 1 is infection. We're talking UTIs, vaginal infections, you name it. And number 2, dehydration. It kind of tricks the body into releasing oxytocin, which, yep, causes contractions. The good news is we can often treat both of these.
So you walk into the room. What's your first move? These are your priority actions, and you got to know them in order. First, get that patient on her left side, that left lateral position. It's all about boosting blood flow. Second, hydrate. We're talking an IV fluid bolus to try and stop that oxytocin. And third, you immediately get that fetal heart rate monitor on.
And that is exactly why the fetal heart rate is so important. Fetal tachycardia, a heart rate that's staying above 160, is one of the very first, most reliable signs of maternal infection. So if you see that on the monitor, your brain should immediately go, okay, where's the infection?
Okay, listen up, because this right here is pure NCLEX gold. This is the whole point of everything we're doing. The primary goal is not to stop the birth forever. It's to delay it, just for about 24 to 48 hours. And why is that? Because that's the window we need for corticosteroids to kick in and help mature the baby's lungs.
So how do we buy that time? We use 2 different types of meds. On one hand, you've got tocolytics. Think nifedipine, think magnesium sulfate. Their job is to stop labor contractions. On the other hand, we give corticosteroids like betamethasone. Their job is to mature the baby's lungs. So, one stops the train, the other preps the passenger. 2 different jobs working together.
Okay, huge safety alert. This is a classic NCLEX trap, so write this down. You never, and I mean never, give nifedipine and magnesium sulfate at the same time. Why? Because they both relax smooth muscles, and if you give them together, you can cause a massive drop in blood pressure. Super dangerous for both mom and baby. This is a critical point. All right, your patient is on a mag sulfate drip. You have to be watching for toxicity like a hawk. Here are your 3 big red flags, the ones that mean you act now. Respirations under 12. Urine output less than 30 milliliters an hour. And absent deep tendon reflexes. If you see just one of these, what do? You stop that infusion immediately. And after you stop that infusion, you better know what's next. You need the antidote. This is a pure memorization question for the NCLEX. The antidote for mag sulfate toxicity is always calcium gluconate. Just burn that into your brain.
Okay, let's do a quick knowledge check. Rapid review. You ready? First up, what is the #1 priority goal when treating preterm labor? The answer? Delaying that birth just long enough for those corticosteroids to work their magic on the baby's lungs.
All right, next one. You've got magnesium sulfate toxicity. What's the antidote you need? Stat.
Calcium gluconate. You can't forget that one. See, you got this. Preterm labor really just comes down to priorities and safety. Go ahead and save this for your final NCLEX review. And hey, drop a comment and let me know what topic you want me to break down next.